Hi, good afternoon, everyone, and thank you for joining us for today's webinar, a joint presentation between the West Virginia University and the West Virginia Bureau for Public Health. Today's webinar, A Close Look at Lyme Disease in West Virginia, will be co-hosted by Dr. John Guilfoose and myself, Miguella Mark-Carew. We're going to mute our display so that we can make sure that you're focused on the slides. This webinar is funded by the CDC Epidemiology and Laboratory Capacity Cooperative Agreement, so thank you to CDC for allowing us to have public health and medicine work together on this important issue. Additionally, for those of you seeking continuing medical education credit, a credit record and evaluation will be emailed to you after the completion of this webinar. If you have any questions at any time, there should be a section on your screen for that. And also, please let me know if you can't hear us. So Dr. Guilfoose and I have divided the talk to cover the key aspects of Lyme disease in West Virginia based on our areas of expertise. Today's webinar will consist of an introduction to Lyme, Lyme disease surveillance in West Virginia, real-world case scenarios, and then we'll end with resources for healthcare providers and others who are interested in the topic. So with that, I'll pass this off to Dr. Guilfoose.
Thanks for joining us again. Again, my name is John Guilfoose. I'm one of the infectious disease docs here at WVU with an interest in vector-borne diseases. In 1977, Dr. Alan Steer, who's actually a rheumatologist, described a new clinical entity of an epidemic oligoarticular arthritis, primarily in children at the time, but this certainly affects adults as well. And some factors about the epidemic suggested an arthropod vector. Now, Dr. Steer was also CDC epidemiology trained, so he was the perfect man to be in the right situation to recognize this as a new clinical entity. Over the next several years, some aspects of the disease became further clarified, such as the fact that it was transmitted most likely from an Oxoides tick, and that it seemed to be responsive to antibiotics. It wasn't until about 5 years later where a Willy Bergdorfer, who actually was worked at the Rocky Mountain Laboratories in Montana, discovered a spirochete in Oxoides ticks. And through some elegant experiments both on animals as well as some serologic studies on patients who were known to have recovered from Lyme disease, was able to definitively prove that the spirochete was the causative agent for Lyme disease. The spirochete now has his namesake, with Borrelia burgdorferi. There are several different species of Borrelia that cause Lyme disease. Throughout this talk, we're going to be speaking really about the sensu stricto, the Lyme disease pathogen from North America. It's a motile spirochete. It is too small to see on routine gram staining. I actually should be more specific there. It's actually too thin to be seen on routine gram staining. But if the appropriate pathologic specimen is submitted, you can visualize the spirochete using special stains. The spirochete has a small genome, and for those of you who are like me and don't have a good sense of how many millions of base pairs other organisms might have, Staph aureus and Pseudomonas are put up there for reference. That small genome has clinical pertinence for several reasons. First of all, the spirochete lacks certain biosynthetic pathways to live freely in the environment. Therefore, it lives only inside animal cells as a parasite. The clinical implications of that is that culture of the organism is not simple, and routine cultures that we perform, such as blood cultures or wound samples, will not grow this organism. Other clinical implications are that this organism does not produce toxins or proteases, and that most of the symptoms we see from Lyme disease are actually due to the host immune response. Lastly, but very important, the spirochete does not have the genetic wealth to carry with it certain enzymes that can inhibit the antibacterials that we use in clinical practice. We all know this is becoming increasingly important for organisms such as Staph aureus and Pseudomonas, as well as many others. But spirochetes such as Borrelia burgdorferi are not becoming resistant to antibacterials at this point. The natural history of B. burgdorferi starts really from transmission from the tick into the skin via tick saliva. There you have local proliferation, dissemination, and then prolonged low-level survival. And while on the previous slide I was talking about what the spirochete is not good at, I should sing its praises, and what it's good at doing is surviving for prolonged periods of time. Usually the joints and the nervous system are the reservoirs of primary concern. The natural history of Lyme disease also eventually has immune clearance. And this is very important. So eventually, if left untreated, fatality is rare. This is a disease much more of morbidity rather than mortality. So after immune clearance, you can get reinfection, and sometimes that occurs even if a person has been previously treated with antibacterials.
So Borrelia burgdorferi would not be an agent of concern were it not for its tick vectors. In the U.S., 2 species of black-legged ticks are known to transmit the spirochete, Ixodes pacificus and Ixodes scapularis. Ixodes pacificus is aptly named as it is mostly found on the Pacific coast, in states such as Washington, Oregon, and California. Infected ticks of this species can transmit Lyme disease and the tick-borne rickettsial disease anaplasmosis. In nature, wild rodents and other mammals are reservoirs of Borrelia burgdorferi. The second tick, Ixodes scapularis, is the species that causes concern in the Midwest and eastern United States. It is commonly referred to as the deer tick. Ixodes scapularis also transmits Lyme disease and anaplasmosis and can transmit babesiosis, a tick-borne protozoan disease. Ixodes scapularis has been found in the majority of counties in West Virginia, as you'll learn more about later when I discuss tick surveillance for Ixodes scapularis in the state. Shown here is a CDC map of the distribution of Ixodes pacificus in the U.S. Based on CDC's surveillance, this tick species has made it as far east as Utah and Arizona. Shown here are 3 life stages of Ixodes pacificus, the larval, nymphal, and adult stages. The 2 life stages that are most associated with transmitting human diseases are the nymph and adult stages. Female ticks only transmit the disease. Here is a CDC map showing the distribution of Ixodes scapularis. This tick has a greater distribution over Ixodes pacificus. It has also been found as far west as Texas and in states along the East Coast. Shown here are the larval, nymphal, and adult stages of Ixodes scapularis. As with Ixodes pacificus, the nymphs and adult stages are mostly associated with transmission of human disease. The reason for this is surprisingly simple. Nymphs avoid being discovered because of their small size, making it easy for them to stay attached to the host long enough to transmit Borrelia burgdorferi. Adults are much larger and are therefore more easily spotted. They are usually removed before they can infect hosts. Let's take some time to go through the 2-year life cycle of Ixodes scapularis by season and life stage. Female deer tick lay their eggs in the spring, usually near the site where they detach from their hosts. The eggs begin to hatch into 6-legged larvae during the late summer, reaching their peak activity around August or September. Larvae are pathogen-free at this point, since Borrelia burgdorferi cannot be transmitted from the female to her eggs. Larvae wait on the ground until they come into contact with small mammals or birds. Once attached, they feed on the host, engorging themselves over the course of a few days. Larvae are not infected with Borrelia burgdorferi, but may pick up the pathogen during this blood meal if their hosts were infected. Infected larvae can subsequently transmit Borrelia burgdorferi during their second and third blood meals as nymphs and adults, respectively. However, it is uncommon for larvae to be infected at this stage, and at this stage poses the least amount of risk of transmission compared to the nymph and adult stages. After feeding, larvae drop off the host and molt into the next life stage, the nymph stage. Nymphs are inactive during the winter and early spring. When the weather starts getting warm, usually May through July, nymph activity begins. Year 2 of the tick cycle begins as host-seeking nymphs hang out near vegetation on the ground or wait for small mammals or birds. The nymphs then latch onto hosts and feed for 4 to 5 days, engorging with blood and swelling to many times their original size. If previously infected during the larval stage, the nymphs may transmit the Lyme disease spirochete to their hosts. If not previously infected, the nymphs may become infected if the host, such as the white-footed mouse, carries the Lyme disease spirochete from previous infectious tick bites. After taking a blood meal, the nymphs drop off the host and into the leaf litter where they molt into adults. Adults actively seek new hosts throughout the fall, waiting on grass blades or leaf tips to latch onto white-tailed deer, their preferred hosts, or other larger mammals, including humans, dogs, cats, and other domestic animals. Peak activity for adult deer tick occurs in late October and early November. Adult ticks are dormant in the winter. They feed, mate, and the female lays several thousand eggs in the spring, continuing the life cycle. Where there are appropriate habitats for Ixodes pacificus and Ixodes scapularis, there are cases of Lyme disease. But there are also cases reported in counties where these vectors have not been identified. Travel-associated cases are commonly reported across the U.S., especially when visitors have traveled to highly endemic areas in the Northeast and Midwest. Here are a series of maps showing the distribution of Lyme disease cases starting back in 2001. You can see cases were concentrated in Minnesota and Wisconsin in the Midwest, and from southern Maine to Maryland at the time. 10 years later, in 2011, we see a southern and western expansion of reported cases. Most counties in Wisconsin and Pennsylvania reported Lyme disease that year. In 2013, southwestern Virginia became a hotbed for human cases, as well as northern Illinois. The eastern panhandle of West Virginia also reported many cases. This will be covered later in the surveillance portion of the webinar. To briefly discuss U.S. surveillance numbers, this figure shows the number of confirmed and probable cases reported in the U.S. from 1995 to 2013. Probable cases were added to surveillance data in 2008, adding at least 5,000 more cases to national surveillance numbers each year. In recent years, roughly 30,000 cases of Lyme disease have been reported annually, though CDC estimates about 300,000 diagnosed cases of Lyme disease each year. Surveillance for Lyme disease also includes obtaining clinical data about cases. From the 10-year period from 2001 to 2010, 70% of 154,405 confirmed and probable cases reported EM rashes. 31% reported arthritis. Neurological and cardiac symptoms were less frequently reported. I'll pass it on to Dr. Guilfoose, who will now discuss clinical aspects of Lyme disease. I just want to make sure that everyone is still with us, no questions. Great.
Thank you, Miguella. So as we go over the clinical manifestations, I want you to keep in mind the natural history we went over earlier, and it's really echoed in the clinical manifestations. Now, Lyme disease has quite varied number of clinical manifestations, but hopefully we'll demystify those and show that these are easily defined as we go along. A lot of people like to think of syphilis as a spirochete we all know well that can have an inoculation chancre and then disseminate and cause disease in distant organ systems. And you can think that, or keep that in mind for the Lyme spirochete as well. Just a couple other notes on the clinical manifestations. Although I have a nice ordered outline up there, you can have presentation anywhere along this continuum at any time. So it's not uncommon for a patient to present having never recalled a history of an early localized skin lesion or any of the early disseminated lesions and present with late arthritis. In fact, if you remember, Dr. Steer's initial case descriptions were based upon description of the late disseminated stage of Lyme without the early stages having previously been recognized. So we'll go along and talk about the early localized initial inoculation point where the tick bites you is known as the erythema migrans. One of the first important points to make about this is there is an incubation period associated with this. So usually about a week after the tick bites before the development of the E. migrans. And you can see the range up there. E. migrans rashes occur in most, but not all, patients. And it's important to remember that people may not remember the tick bite. Okay. Now, classically, this is taught as a bullseye rash, but that's only one of the potential clinical manifestations of the E. migrans rash. It can present simply as an enlarging red area without any clearing. So please be familiar with the various appearances. Yeah, erythema migrans is also the stage of Lyme where our diagnosis is clinical. And I'll talk about that again when we talk about our diagnostic tests. So being able to recognize this rash is important. You'll see I have a size criteria up there of at least 5 centimeters. This is not an absolute criteria, but if you're going to make the diagnosis with confidence, you want it to be greater than 5 centimeters. There are a couple important differentials to keep in our mind for erythema migrans. The most important is that of insect bite hypersensitivity. Up in the upper right-hand corner is a slide from the CDC website of an insect bite hypersensitivity. And as you can see, it has a lot of the general characteristics you might think for EM. It has a general round appearance. It almost looks like it has some clearing. Some of the differences, however, will be the time course. So it tends to occur much more rapidly than the EM and not last as long. Other important mimics of erythema migrans include bacterial cellulitis. Ways that I could help differentiate that clinically, hopefully the E. migrans would be more well demarcated and more or less ovoid or round in shape, whereas cellulitis doesn't tend to have quite as well demarcated borders, but sometimes it's difficult to tell. Starry, the southern tick-associated rash illness, is a very good mimic of E. migrans rash, with some important differences from Lyme disease in that the transmission vector is not the Axoides tick, but it's a different Lone Star tick. And I think most importantly, there's no long-term sequelae to untreated starry. Whereas if Lyme disease goes untreated at the level of E. migrans, you can expect potentially to have some late manifestations. Also during early localized Lyme, you can have an ILI, that's an influenza-like illness, which all of us are familiar with as fatigue, myalgias, headaches. You can get fevers with early disseminated Lyme. However, it doesn't tend to be, I don't think of this as a really febrile disease process. In fact, if you do have a patient who's very febrile with an erythema migrans rash, please don't forget about the co-pathogens that could potentially have been transmitted from the Axoides tick bite. Anaplasmosis and Babesia have fever as a much more common presentation than Lyme disease. As you proceed with the natural history of infection and you get early disseminated Lyme, you can have additional skin lesions away from the tick bite. You can also get early manifestations in the CNS, central nervous system, as well as the heart. The neurologic manifestations, the classic three, are meningitis, Bell's palsy, and a painful radiculopathy. However, patients do not have to have all three of those. The lymphocytic meningitis is a perfect mimic of any other aseptic picture. It tends to have a lymphocyte predominance, normal glucose, mildly elevated protein. And again, patients are often seen in the summertime where your differential would include the arbovirus as well as enteroviruses. The cranial nerve palsies are some of the most characteristic of Lyme disease, especially if it's facial nerve palsy and bilateral. The radiculopathy tends to be painful more than motor. And again, it's something discovered in the workup of a patient complaint and doesn't have structural abnormalities to explain this neurologic dysfunction. Uncommon but important to recollect are an encephalomyelitis, meaning the parenchyma of the brain or even the spinal cord can be involved in early disseminated Lyme disease. And it's a very good mimic of MS, both on imaging as well as clinical presentation. The cardiac manifestations of Lyme disease tend to be some of the most dramatic when they occur. And symptoms can be nonspecific, such as palpitations or shortness of breath, or can be really dramatic, like syncope. The cardinal finding is prolongation of the PR interval, and it can vary in degree of severity up to and including complete heart block. A temporary pacemaker may be required, and I want to take a minute to underline that word temporary. The natural history of cardiac Lyme, either treated or untreated, is resolution of the cardiac involvement, which is really a wonderful thing. However, we still do recommend treating this so as to prevent additional complications. If you remember in the natural history, I mentioned that Lyme disease tends to self-resolve in most patients and be does not have a high degree of mortality. When mortality is seen in Lyme disease, it tends to come at this stage from cardiac manifestations. Moving on to the late manifestations of Lyme disease, these are primarily going to be neurologic and arthritic in the United States. There are some late skin findings in European varieties of Borrelia infection, but not over in the United States here. The arthritis, again, if anyone wants to read a wonderful description of a true natural history of a disease process, Dr. Steer's 1977 initial description of the disease process reminds me of a few very important terms. Number one, asymmetric. That helps us differentiate this from several other collagen vascular diseases. Few joints at a time rather than many. Joints tend to be quite swollen and have notable effusions. Also important is the natural history of episodic attacks. Now, the attacks can start abruptly and last weeks to months. Some patients experience multiple attacks, others experience a single attack. The natural history also says that even without treatment, most people get better. However, that getting better may take years. Now, unlike infection with other, say, pyogenic microbes like Staph aureus, where the joint would often be destroyed afterwards, infection from the Borrelia spirochete often leaves very little joint dysfunction after the arthritis resolves. I do want to mention that there is an autoimmune arthritis that can be accompany Lyme infection called antibiotic refractory Lyme arthritis. And I'm going to mention this again when we talk about some of the treatment approaches for patients with Lyme disease. But certain HLA haplotypes seem to be overrepresented in these patients who suffer from chronic arthritis after Lyme disease. Now, I just want to take a minute to mention this is definitely arthritis, not multiple arthralgias. These are very objective clinical findings. The chronic neurologic findings of Lyme disease tend to manifest as one of two possibilities. One is a chronic axonal polyneuropathy. The two clinical manifestations there are either a stocking glove neuropathy or even a painful spinal radicular discomfort. Now, this is important to keep in our mind as you're working up your patient with, say, a symptom which you think could be attributable to, say, a vertebral disc, like a sciatic type discomfort. But when you can't find anything structurally on MRI to explain the pain, keep in mind that Lyme disease can cause such neuronal dysfunction. Lyme encephalopathy is important for us to talk to. Patients, many patients who have Lyme disease complain of subtle cognitive changes, complain of sleep disturbance and fatigue. That's well known and accepted. Okay. The debated component of this diagnosis is not whether or not patients suffer from those symptoms, but whether or not this represents CNS infection or sequelae of infection elsewhere in the body, such as arthritis or carditis. I recommend anyone to read the viewpoint in the CID article in 2014, where it's stressed that a lot of times patients who are diagnosed with Lyme encephalopathy may actually have undiagnosed encephalitis, but just have not had maximum workup, such as MRI and lumbar puncture or EMGs. Just a few quick slides on the post-Lyme disease syndrome. The post-Lyme disease syndrome is a nonspecific compilation of symptoms such as fatigue, widespread musculoskeletal pain, and cognitive dysfunction of unknown etiology. There are multiple hypotheses as to the etiology, such as a slow resolution of the inflammatory process to the previously widely disseminated B. burgdorferi. Currently available evidence does not support persistent infection as the cause of the ongoing subjective symptoms after having undergone a recommended course of antimicrobial therapy. Important to know that a lot of patients who are referred to Lyme disease specialists do not have Lyme disease. The first study cited up here is actually from a Lyme endemic area, and as you can see, 57% of the patients referred to a specialist did not end up having Lyme disease by objective criteria. In a non-endemic area, an even smaller number. Now here in West Virginia, we are sort of peri-endemic, as we're going to talk about in the next few slides. If you define post-Lyme disease syndrome, various inclusion and exclusion criteria have been proposed. First and foremost, to have post-Lyme disease syndrome, you need documented Lyme disease. And we'll talk about how to diagnose Lyme disease in a couple slides. Secondly, you need to have ongoing symptoms after having undergone appropriate antimicrobial therapy and have resolution of any objective findings that were there previously. For example, if you had erythema migrans, it should have resolved. If you had facial nerve palsy, it should have resolved. But the ongoing subjective symptoms need to be present for quite some time. And this is very important to counsel our patients, that we shouldn't expect them to feel normal immediately post-therapy. You can have up to 6 months before you start entertaining this as a post-Lyme disease diagnosis. Okay. Exclusion criteria include the establishment of any definitive alternative diagnosis, active co-infection, and any objective abnormalities on labs or physical findings. When using these inclusion and exclusion criteria, the 4 randomized placebo-controlled trials have demonstrated that prolonging antimicrobial therapy has not proven to be beneficial to patients. However, I will stress it has been demonstrated to have significant potential for treatment-related adverse events. These adverse events have included case reports of death from Lyme infections, fungemia, C. difficile infections. Not mentioned up there, and perhaps the most troublesome, are false attributions that patients apply to Lyme disease and missed diagnoses. The CDC website has several reports of people who have had alternative diagnoses and been mistakenly treated with prolonged antimicrobials for post-Lyme disease syndrome. Further research is needed so we understand why patients suffer from post-Lyme disease syndrome, and as well as controlled trials that test new approaches to treatment besides ongoing antimicrobials. Now I have one slide on chronic Lyme disease. So chronic Lyme disease is a term used by some practitioners when patients have ongoing headaches, fatigues, widespread musculoskeletal pain, and cognitive discomfort, but do not have objective evidence of B. burgdorferi infection. Again, if patients had these complaints and had evidence of B. burgdorferi infection, an appropriate term would be post-Lyme disease syndrome. There is no ICD-9 or 10 code for this disease process, and it's debated as to its existence. Moving on to diagnostics in Lyme disease. Now, very important statement. It requires a combination of both clinical findings, the correct clinical scenario, and laboratory evidence to diagnose Lyme disease appropriately. In most situations, a laboratory test is going to be required to confirm Lyme disease. The one exception to that is at the diagnosis of E. migrans rash. The reason being is that antibodies, which we rely upon heavily for our diagnostics for Lyme disease, are not expected to be positive yet for E. migrans. So again, this is a clinical diagnosis at that point. If you divide the testing into both direct and indirect, we primarily use indirect testing for B. burgdorferi infection. The direct testing methods of culture and PCR, unfortunately, are notably insensitive at this point. I don't know any clinicians who are happy that serology is what we're going to rely upon to diagnose Lyme disease. The reasons for that is serology always requires interpretation, requires us to have an appropriate pretest probability, and there are false positives and false negatives. False positives can occur in the general population. False positives can occur in healthy and unhealthy individuals for reasons I listed above, including polyclonal B-cell activation, autoimmune diseases, and other infections. False negative serology can occur if you check serology too early on in the disease process, as well as if you check serology after treating a patient before they've had time to seroconvert. That being said, if performed on the appropriate patient population, serology in the setting of Lyme disease does work well. It truly does. So, in Animals Internal Medicine suggested that you want about a 20% pretest probability to make these tests perform well. I know myself as a clinician, I don't know if a person has a 20% pretest probability. So what is useful instead is making sure that these 3 criteria are present before testing a person for Lyme disease. Number 1, you want to make sure they have risk of exposure to ticks. Now, I would argue that almost everyone has potential exposure to ticks if you go outside or have pets, or have that's the low-hanging fruit on the slide. Geography, Very important. You want to live in an area or have traveled to an area endemic for Lyme disease. A lot of the patients I've seen with Lyme disease actually have got their Lyme disease while on a trip, while traveling. So travel history is very important when assessing a patient for Lyme disease and deciding whether serology is pertinent or not. And lastly, you want to make sure that the clinical symptoms are consistent with Lyme disease. Again, having one of the either E. migrans or early disseminated or late manifestations that we talked about. You shouldn't perform serology in patients solely with an E. migrans rash. Why? Again, you don't expect the serology to be positive yet. You don't want to use testing in a screening method on asymptomatic patients. And testing patients with only non-specific symptoms is more likely to produce false positive results rather than true results. The current diagnostic modality for serology entails a two-tiered testing method, and this is familiar to a lot of clinicians for a lot of other disease processes such as HIV and syphilis, where we use a very sensitive screening test and then a very specific confirmatory test. The screening test is often an ELISA performed, and then only if positive should the Western blot be performed. Clinicians have to take a minute and process one important fact before interpreting Western blot, and that's how long symptoms have been present. If symptoms have been present for greater than 1 month, the expectation is that the IgG Western blot should be reliable and really is a more reliable test than the IgM in that setting. If, however, the symptoms have been present for less than a month, both the IgM and the IgG should be looked at. I would say by far the most common mistake that I see as a clinician is people interpreting the IgM when symptoms have been present for greater than 4 weeks. And I think Dr. Mark-Carew also mentioned that's a problem from a surveillance standpoint. Here's a CDC slide of the two-tiered testing method, and I think it's echoing what I said on the previous slide, and we'll talk about this slide again in a few days, but please note, again up there, before interpretation of the Western blot, you want to look and see how long patients' symptoms have been present, and only order a Western blot if the screening ELISA is positive. I include this slide up for one reason, and this is if you're working up a patient's complaint, expect objective abnormalities. For example, if you're working up a neurologic complaint and you apply maximum diagnostic modalities, you should find something objectively wrong. The spirochete does leave telltale signs, and we need to make sure we look for them, and don't just tell a person they have Lyme disease without us being able to find some objective abnormality. For example, in the neural complaints, you could use MRI, CSF sampling. You can even look for local antibody production. You can use an EMG and even neurocognitive studies. None of these is specific in and of themselves, but along with a clinical presentation, an epidemiologic history that fits, and laboratory results can help us really pin down the diagnosis. As we move on to treatment, a lot of the treatments should look very, very familiar. These are drugs such as doxycycline, as well as beta-lactams such as amoxicillin and cefuroxime are commonly used drugs. Notably absent from the list of beta-lactams are first-generation cephalosporins. Again, these drugs are very commonly used in the treatment of bacterial cellulitis or skin infections, but do not have activity against the Lyme spirochete. Azithromycin has some activity, but is not considered first-line therapy as it has a greater risk of progression of disease processes and inadequate therapy. So there are times when oral therapy is inadequate, and I'll talk about that on the next slide, but in general, oral therapy is preferred. Most of the time we use doxycycline simply because it also would treat any potential co-infecting organisms. But the amoxicillin and cefuroxime work very well. If you do have to go to IV therapy, ceftriaxone generally is used because it's once-a-day therapy, where cefotaxime and penicillin require more frequent dosing intervals. The duration of therapy is varied depending upon the particular clinical manifestations, but as you can see up there, there's no times when duration is extended beyond 10 to 28 days, except one exception on the next slide. So never condone to treat people for years with these antimicrobial agents. So IV therapy is preferred when CNS manifestations are present. There's always an exception in all the guidelines mentioned about isolated cranial nerve palsy that you could treat with PO therapy, but in that situation you have to be sure there's not concomitant meningitis. and that can be either clinical judgment or objective criteria, such as looking for spinal fluid abnormalities. Cardiac disease, if you remember the natural history of cardiac disease, I mentioned itself resolves with or without therapy. However, simply due to the fact of the severity of illness, patients are often in the hospital with a temporary pacemaker. IV therapy is condoned in that situation until patient's heart block improves, then transition to PO therapy is advised. Arthritis represents the only condition in which you can justifiably treat beyond a 28-day course. However, it doesn't mean permanent treatment. It means 1 or 2 courses of antimicrobial therapy, either a 28-day course of oral therapy followed by another 28-day course of oral therapy, or you can try an IV round of therapy. But please remember that there's that antimicrobial refractory Lyme arthritis that sometimes has become autoimmune in nature and will not respond. A couple other treatment considerations. You really want to treat early on for Lyme disease, really as a mechanism to prevent the occurrence of late disease. You also want to counsel your patient that recovery may take time. And the time you need to educate your patient may be weeks to months. And this is important so that they are not discouraged and seek alternative therapies, alternative diagnoses. Sometimes you just have to wait. I want to also mention the Jarks-Herxheimer reaction. This is a response, an immune system response to a high spirochete burden upon initial therapy when the immune system is responding to dying organisms. This doesn't occur more than one time after the initial approach, and has made its way into some literature as something that happens more routinely to patients, but it's really not common, but has been described early on in treatment courses. When you talk about prevention of Lyme disease, these can be divided into pre-exposure and post-exposure prophylaxis. The pre-exposure prevention strategies are really myriad in nature, but a lot of them revolve around trying to prevent the tick from attaching or being attached long enough to transmit the organism. Again, and that's somewhere between 36 to 48 hours of time. And I advise that you check out some of the cartoons and examples on the CDC website. But again, applying insect repellents as well as doing tick checks are cardinal to pre-exposure prophylaxis. The concept of post-exposure prophylaxis is utilizing doxycycline as a single dose after a tick has bitten a patient. You have to satisfy all of the following criteria to really make this worth doing. In other words, the number needed to treat be such that you're doing benefit rather than harm, because the antibiotics do potentially have risk. You want to make sure that if you decide to treat a patient with doxycycline after they've found a tick attached to them, that the local rate of infection of the Ixodes ticks with the B. burgdorferi pathogen is greater than 20%. I'll mention that nowhere in West Virginia at this point has achieved those rates. And that's an area we also don't have appropriate data across the entire state. So at least the areas where we do have that data, nowhere is above 20%. You want to make sure that the tick attached was actually an I. scapularis if possible. And you want to make sure that the tick has been attached for more than 36 hours. This is often difficult for a patient to estimate, but a degree of engorgement of the tick can give you an estimate there if they bring the tick into you or take a picture of it. You have to start the prophylaxis early and make sure doxycycline is not contraindicated. Remember, doxycycline is a well-tolerated drug, but is contraindicated in pregnancy as well as children younger than 8 years of age.
Okay. Though no cases have been reported since the late 1970s, Lyme disease only became a nationally notifiable condition in 1991. CDC's National Notifiable Diseases Surveillance System is a nationwide collaboration that enables all levels of public health, local, state, territorial, federal, and international, to contribute health information that can be used to monitor, control, and prevent the spread of infectious and some non-infectious diseases and conditions. Together with the Council of State and Territorial Epidemiologists, or CSTE, consistent standards, tools, training, and technology are developed and implemented to ensure that the diseases reported to the system are integrated within each state. CSTE develops the case definitions for nationally notifiable conditions that are recommended for use when reporting. The current Lyme disease case definition is the 2011 update. Local health departments conduct Lyme disease case investigations that are then verified by an epidemiologist at the state health department. That person is currently me. Through the National Electronic Disease Surveillance System, surveillance information is then passed on to CDC for national reporting purposes. The Lyme disease case definition sets the criteria for determining the case status of persons under surveillance, meaning anyone who was tested for, treated for, and/or diagnosed as having Lyme disease. West Virginia strictly adheres to the 2011 case definition, whereas other states, particularly highly endemic states, may loosen the criteria for reporting cases. A surveillance case can be assigned one of four case statuses: confirmed, probable, suspected, or not a case. It is important to note that surveillance cases are not always diagnostic cases, meaning that there are instances where a person diagnosed as having Lyme disease by a physician may not meet the surveillance criteria of a confirmed case. In order to fulfill the clinical criteria of the Lyme disease case definition, a case must either have EM of greater than 5 centimeters in diameter or a late manifestation of Lyme disease, which can affect musculoskeletal, nervous, and cardiovascular systems, as Dr. Guilfoose previously described. Specific laboratory tests fulfill the laboratory criteria portion of Lyme disease surveillance cases. Positive culture for Borrelia burgdorferi, a serology screen with reflex to Western blot, positive CSF for Borrelia burgdorferi when the titer is greater than in a serum sample, and a single IgM Western blot. The two-tier testing strategy is strongly recommended by CDC, so let's go over it one more time. The first test is the EIA-IFA to screen for Lyme disease infection. If negative, an alternative diagnosis should be considered. If positive or equivocal, a Western blot should be run. Depending on the time of illness onset and specimen collection, either IgM, IgG, Western blots, or just an IgG Western blot should be ordered. IgM and IgG Western blot should be utilized within 30 days of symptom onset, while only the IgG Western blot should be ordered after 30 days from symptom onset. There are a few things to consider when ordering the two-tier testing. Western blot should never precede serology screens. The EFA-IFA screen test has a very high sensitivity, meaning that almost every true Lyme disease case should test positive. But there are some instances, as Dr. Guilfoose described, where a person can test positive and not have Lyme disease. This can be due to cross-reactivity when a person has a different medical condition, such as anaplasmosis, syphilis, or leptospirosis. For this reason, it is important to verify any positive or equivocal screens with Western blots. Western blot should not be run if the EFA-IFA is negative. Detection of IgM antibodies is helpful for identifying patients during the first few weeks of infection. It is important to reiterate that a positive IgM Western blot is only useful for surveillance within 30 days of illness onset. Otherwise, even if it is positive, it will not fulfill the laboratory criteria of the surveillance case definition. Finally, the Western blot banding pattern must meet the criteria to be considered positive. Again, for IgM Western blots, 2 out of 3 bands should be present for the test to be positive, and for IgG Western blots, 5 out of 10 bands must be present to be positive. Here are some tests that are not appropriate for surveillance purposes. Even if the tests are positive, they will not fulfill the laboratory criteria. Please be mindful again that PCR, which is commonly used for other diseases, is not an appropriate test for Lyme disease. To fulfill the epidemiologic criteria, a case should have been in a potential tick habitat, so a woody, brushy, or grassy area within 30 days of onset of EM in a Lyme disease endemic county. Please note that a tick bite is not required since many cases don't recall being bitten. Endemicity describes a county in which 2 confirmed cases have been acquired within that county, or in which established populations of Ixodes scapularis are known to be infected with Borrelia burgdorferi. The two cases must fulfill the laboratory criteria based on the two-tier testing strategy and have had EM. Let's go through the different case classifications. To be a confirmed case, there are three possible scenarios. A case with erythema migrans and known exposure in an endemic county, a case with EM and laboratory evidence of infection without known exposure in an endemic county, and a case with laboratory evidence of infection and at least one late manifestation of disease. For probable cases, there is only one scenario, a case with laboratory evidence of infection and physician diagnosed but lacking clinical evidence of infection. Suspected cases have two scenarios. A case with EM with no known exposure and no laboratory evidence of infection, or a case with laboratory evidence of infection but there is no clinical information available. Please note that only confirmed and probable cases contribute to national surveillance numbers, so suspected cases are not included. Hopefully you're all familiar with this wall chart. It's the reportable infectious disease wall chart that the Division of Infectious Disease puts out every year. Confirmed and suspected cases should be reported to the local health department of the patient within 1 week. Public health would like any confirmatory lab disease reports along with EM rashes to be reported. We also ask that both laboratorians and healthcare providers report to us. The following slides detail the responsibilities of key stakeholders in the Lyme disease surveillance system. The reporting responsibilities of laboratories and healthcare providers are basically the same. We want you to report suspected and confirmed cases of Lyme disease within 1 week, and also to follow the national guidelines for Lyme disease testing, meaning using the two-tier approach of the serology screen and the reflex to Western blots. Local health departments are responsible for conducting appropriate Lyme disease case investigations, which consists of contacting the physician who ordered Lyme disease testing, using Form A to collect clinical information about the case, making contact with cases who reported EM, educating the patient and family about Lyme disease prevention, and reporting all case information into the West Virginia Electronic Disease Surveillance System. Here's a screenshot of Form A, which I'll go into more a little later. Basically, we'd like for you to share information about the date of illness onset, the presence of EM, any late manifestations of Lyme disease, if you diagnose the patient as having Lyme disease, what testing you ordered, why you ordered the testing, and if any antibiotics were prescribed. Finally, the state health department is responsible for educating the public about Lyme disease, educating healthcare providers and laboratories to report Lyme disease to the local health department within 1 week, educating providers about the use of the recommended two-tier testing approach, and conducting tick surveillance when and where ticks are active. The Lyme disease surveillance is pretty straightforward. It all starts with a bite from an infected tick, and the Borrelia spirochete is transmitted to the patient. The patient visits a healthcare provider to seek medical attention. The healthcare provider evaluates the patient for Lyme disease and orders testing. Laboratorians send positive results to the local health department and state health department so that public health can initiate case investigations. Once investigations are complete, the cases are assigned a case status, and surveillance information is disseminated to the general public. CDC uses compiled data from states to share national surveillance data. Another aspect of the system is more tick-centric. Animals, including humans, are hosts for ticks, and the state health department can use tick data to drive future surveillance efforts. Currently, we have projects aimed at identifying and testing ticks for tick-borne disease pathogens. Veterinarians across West Virginia and in neighboring states have been participating in the West Virginia Tick Submission Project, whereby ticks found on animal clients are sent to the state public health entomologist for identification. Another project with the West Virginia Division of Natural Resources involves identification of ticks found on deer from game check stations across the state. Additionally, healthcare providers and private citizens also send ticks to us, allowing us to better understand the ecology and epidemiology of Lyme disease in West Virginia. One aspect of the system that can be improved is better quality of data about Lyme disease cases. We hope that by using Form A, better patient information can be relayed to local health departments to improve reporting in the state. Through participation of stakeholders in the Lyme disease surveillance system in West Virginia, Public Health reported 1,283 confirmed and probable cases during the 15-year period from 2000 to 2014. You can see the case reports increased after the 2008 and 2011 case definition updates. Here are how cases break down geographically. 3 counties in the Eastern Panhandle, Berkeley, Jefferson, and Morgan counties, represented greater than 100 cases each year during the 15-year period. Hampshire, Harrison, Kanawha, Mercer, Mineral, and Monongalia County reported between 11 and 100 cases during the 15-year period. All other counties reported 10 cases or less. For public health purposes, West Virginia is divided into 6 regions. The Eastern region consists of 12 counties that accounted for 88.2% of Lyme disease cases from 2000 to 2014. Keep in mind the counties that are highlighted in red. The Northeastern region has 7 counties and accounted for 43 of the total cases during this time period. The Northwestern region consists of 14 counties and accounted for 34 cases during this time period. The Western region consists of 8 counties and accounted for the lowest number of cases in West Virginia, with only 6 cases. Based on tick surveillance, we believe that other ticks are playing a role in human diseases in this region. The Southern region accounted for 50 cases among the 9 counties in this region. Ixodes scapularis has been identified in many counties in this region, and active tick surveillance plans are underway for the spring, summer, and fall. The Central region, Kanawha County had the most number of cases of the 6 counties in this region. Most of these are likely due to travel-associated infections, but it's not unlikely that there are infected tick populations in Kanawha County. So to summarize, there were 1,283 confirmed and probable Lyme disease cases reported during the 15 years. Only 7 counties did not report cases. And it's important to note that the counties bordering Maryland, Virginia, and Pennsylvania, 3 states that have high incidences for Lyme disease, reported the most number of cases. And as I said, for Kanawha County, the numbers include residents who may have acquired Lyme disease outside of West Virginia. So the counties that were highlighted in red were actually the Lyme disease endemic counties as of 2015. 5 counties in the eastern region of West Virginia became endemic due to the presence of cases with EM and confirmatory lab results. Hancock County became endemic because of a population of Borrelia burgdorferi ticks. And Wood County may seem a little odd being on the other side of the state, but upon a closer look, Athens County and Washington County in Ohio have known Ixodes scapularis populations. So it's not unlikely that there are infected populations in that area. And I should also note that these results are based on active tick surveillance, our veterinary submissions, and other resources. Oops, sorry about that. Prior to the start of active tick surveillance by our state public health entomologists, little was known about the distribution of Ixodes scapularis and was based on anecdotal evidence. In 2011, Public Health began working with various partners, including veterinarians and the Division of Natural Resources, to better understand where Ixodes habitats are located across the state. From these efforts, Ixodes scapularis has now been identified in 42, or 73.6% of West Virginia's counties. Borrelia burgdorferi infected ticks have been identified in Hancock, Marion, and Jefferson counties. Tick testing is a high priority of our group for this year. However, it's important that I stress that this is only for surveillance purposes and not for diagnostic purposes. So let's take a closer look at Lyme disease surveillance data for 2014. You can see the total number of Lyme disease case investigations was 397, which was up from 2012 and 2013. Probable and confirmed cases only accounted for 34.2% of our case investigations. Sadly, over 50% of our case investigations ended up being not a case. 230 of our 397 were not cases. Interestingly, physician-diagnosed cases accounted for 52.4% of our total case investigations, but only 34.2% of our cases were confirmed or probable. Another interesting fact is that physician-diagnosed not cases were accounted for 18% of our total case investigations. And lost to follow-up case investigations accounted for 21.7% of our cases. So let's take an even closer look at not a case investigations for 2012. Kudos to public health for not ascertaining EM cases as not a case, because EM cases should either fall into confirmed or suspected case categories. Interestingly, cases with arthritis with joint swelling accounted for 23% of not a case investigations. While it's probable that other diseases may contribute to arthritis with joint swelling, it's probably likely that many of these cases did in fact have Lyme disease. A close look at the laboratory section shows that IgM Western blots only accounted for 44.8% of our laboratory criteria. Again, as both Dr. Guilfoose and I stressed, having IgM Western blots as the only test available is not recommended. So is West Virginia underreporting Lyme disease? I think that we are, based on these 4 different scenarios. Public health and healthcare providers can work closer together to improve loss to follow-up rates by getting additional surveillance data about cases. For the last 3, I believe that missing laboratory criteria contribute to these scenarios. And in this case, public health, healthcare providers, and laboratorians can all work closer together to improve these. So hopefully something like this webinar and other methods to improve engagement of stakeholders will allow for surveillance cases to be at or near the total number of diagnostic cases that we see in the state and be representative of the true number of cases of Lyme disease in West Virginia. Prior to the start of 2015, West Virginia had no electronic laboratory reporting, and we are actually the last state of the 50 states to onboard ELR. But we have some glimmering hope here. In February of 2015, we onboarded LabCorp to our ELR system. Last month, we onboarded Mayo Clinic. And as of this month, our Office of Laboratory Services, Quest Laboratories, and WVU Hospital Laboratories are in the test system. So hopefully by the end of 2015, we'll have electronic laboratory reporting for all aspects of our surveillance. And I'd like to say that paper-based reporting likely contributed to underreporting because of sending faxes, maybe they didn't go through. So hopefully by the end of this year, we'll have better surveillance numbers for 2016. Continuing with the surveillance data, I just wanted to show the incidence of Lyme disease in our Lyme endemic counties in the eastern region. You can see that Hampshire and Morgan counties have incidence rates of over 100 per 100,000 people, and that's because these are pretty small counties, but they do account for much of our cases. This graph shows the distribution of Lyme disease cases by age and sex. Interestingly, many of our cases are greater than 50 years of age, which segues nicely into our symptoms reported among 2014 cases. While EM accounted for a little less than half of the symptoms reported, arthritis with joint swelling accounted for, and other late manifestations accounted for over half of the symptoms reported. It's likely that maybe we are diagnosing Lyme disease cases too late. So with that, I'll transfer our talk to Dr. Guilfoose, who will go into some Lyme disease case scenarios. And for this portion, we have questions that we'd like for you to answer. So we'll launch the questions when they appear.
Yeah, and hopefully
this works.
The IT part works. So these cases I'm going to go over were either patients that I've seen myself or I've taken phone calls on from around the state. So if any of you providers out there recognize your patient, it may be in fact yours. The Mars line, which we'll talk about at the end, was how I learned about some of these cases. So this first patient was a 32-year-old female, came to the doctor's office with a rash after a tick bite, and she noticed the tick bite attaching near her armpit at 8 o'clock at night while showering. Her husband promptly removed it and flushed it down the drain, unfortunately. She didn't recall if the tick was engorged, but described it as about the size of a pencil eraser. And she thinks it had been attached only that day because she hadn't noticed it the day before that morning. Her symptoms included a rash at the tick site and an overall feeling of tiredness and feeling achy. She was from Webster County and certainly was at risk of tick bites, as evidenced by the fact she had one. And she really came to the doctor's office because she was worried about Lyme disease. Her exam showed a 2-centimeter circular red rash around the tick bite site. There were no labs available at the time of evaluation. The questions we have for this case, let's start with, should she be diagnosed with Lyme disease and treated for erythema migrans? Let's see if we can get some audience participation here.
Yay, it's working.
Excellent, so it's working. Okay, we're gonna keep the poll open for about 10 seconds.
Sure.
All right. So we.
When it says 30.
Oh, 30 seconds. Okay, so we have 10 more seconds, and we'll close the poll.
It's completely anonymous.
Yes, I promise we can't see anything.
Okay.
All right.
I'll wait for you to do it.
Let's go on.
All right.
It's all right. All right, we're gonna keep going on just for the sake of time. Consensus answer, no. She should not be diagnosed with Lyme disease and treated for EM. Let's talk about why. The lesion she's describing is most likely a tick bite hypersensitivity reaction. The lesion has occurred too quickly. Remember, E. migrans has a significant incubation time, usually about a week, and is also less than the 5 centimeters required to make the EM diagnosis with confidence. If there is doubt about the diagnosis, there's nothing wrong with using the underappreciated time as our diagnostic modality. So you can watch her, have her come back to your office in a day or so, 2 days later, and see if the lesion is enlarging or getting bigger, or if it's going away after the tick was removed. Very reasonable. Okay, so should post-exposure prophylaxis with 200 milligrams of doxycycline then be given? Let's open that poll.
Close this poll.
So, okay.
Just kidding.
You know what? We're going to just go on with this one, and the answer on this one is no. She doesn't meet criteria for post-exposure prophylaxis. Reason being, she's from Webster County. As mentioned, we don't know the exact incidence of tick infection with Ixodes, of Ixodes ticks with Borrelia burgdorferi throughout our entire state, but there's nowhere at this point that's greater than the 20% required for post-exposure prophylaxis. It really sounds like the tick that was attached was more a dog tick than an Ixodes scapularis just from the size, but it's really hard to tell from just a description. It also sounds like the attachment time was not long enough. Furthermore, if the patient did meet criteria for post-exposure prophylaxis, being a 32-year-old woman, you'd want to make sure that her pregnancy test was negative. Remember that the beta-lactams, while being valid alternatives for treatment of Lyme disease and E. migrans are not useful for post-exposure prophylaxis. Should the patient be tested for Lyme disease? We do have a poll for that one. Okay, let's look for some volunteer. Let's open the polls. Should the patient be tested for it at this point? Again, this is anonymous. We can't see any answers, but we see percentages. And we'll keep the polls open until 30 seconds total. We have about 10 more seconds. And because I don't know that you guys can see the answers, we're at about, we'll go with the answer here at 30 seconds. You're about an 80-20 split on this one. The answer should be no. Her clinical syndrome is not, and by the way, this is no with a caveat, so I'm going to give you a little caveat. From a pure clinical standpoint, again, you're trying to her clinical syndrome doesn't fit erythema migrans because it happened too quickly and for all the reasons I mentioned before. And serologic testing, even if it were E. migrans, is not requested in those scenarios, not required. For achiness and fatigue, I don't know what to do with those, but she should be educated to basically watch for objective fever. And remember that bacterial cellulitis and other tick-borne pathogens are on the differential from tick bite. So just remember, fevers could be important to keep in mind. She should be educated on how to prevent tick bites and go from there. Now, the reason I mentioned this is not a 100% clear-cut answer is if you did decide to test her for E. migrans, you could do so not for your own clinical benefit, but more in the setting of, for surveillance data. And I'll talk about that more on the next case as well. All right, so next case was a 7-year-old boy who was being seen for a well child visit by his pediatrician, in Clay County, West Virginia. At the point when he was being seen by the pediatrician, the little boy felt well, but his mother had reported that 2 weeks ago he was diagnosed with Lyme disease while at a summer camp in New Jersey. So he'd gone to an urgent care center there and was prescribed amoxicillin. The little boy didn't know of any known tick bites, but had certainly a lot of ample outdoor exposure. And the mother presented medical records that had demonstrated that the urgent care center saw a solid erythematous round rash about 3 centimeters in diameter at that point. They did Lyme serology and ELISA, which was negative. And the real reason the mother brought it up is she was concerned that because of that negative Lyme disease testing, that the urgent care center might have made a mistake in her diagnosis and wanted to know if the amoxicillin needed to be continued. So it prompts some interesting questions. So let's open this up to polling. Do we think the boy actually has Lyme disease? We'll give 30 seconds to answer that one. Got 15 more seconds. And then all right, and again, I'm going to summarize the answers from the audience members. It's about 20-20-60, 20% yes, 20% I don't know, and then 60% say no. I think the consensus answer here on this gentleman, on this little boy, would be yes, that most likely he does have Lyme disease. The clinical diagnosis appears to be appropriate. The boy was visiting an endemic area, that's New Jersey, and was certainly at risk for tick bites. The description of the medical records is consistent with erythema migrans, and again, I need you to recollect that you do not need a bullseye appearance. My advice was that that he should continue to take his amoxicillin for a full 21 days, and that his mother should be expected he should make a complete recovery and have no long-term sequelae, given that the disease process was being treated appropriately early on. How would you explain the negative Lyme EIA serology? And should the test be repeated now? Now, I don't have an easy way to turn this one into a yes-no, so I'll just give you a few minutes to think about this one. In talking to the mother, it was important to basically explain that, that patients with EM lesions are very likely to be seronegative. Since what you're assaying, again, is the immune response, remember that this takes time. usually 2 to 4 weeks for an IgM or 4 to 6 weeks for an IgG response. And also remember that serologic testing is neither required nor recommended in patients who are trying to make a diagnosis of an EM rash. So again, the urgent care center was appropriate. They sent the test even though they didn't have to, but even though the test was negative, they appropriately concluded that the patient did have Lyme disease. So even though the patient is now several weeks out from the likely tick bite, repeat serology is not clinically of use. Okay, it may still be negative due to the fact that the patient was treated during early Lyme disease, and therefore the pathogen was killed before the immune response had time to register serology positivity. If you decided to repeat the test in this scenario, it would be more to satisfy surveillance information. It's not right or wrong, it's just it wouldn't be clinically useful in that scenario. Case 3, very fascinating case that I saw here not long ago. A 21-year-old came to see us about 2 weeks after a recent hospitalization in Indiana. He had actually been riding his bike and he passed out and crashed his bike. He was okay from a trauma standpoint, but was diagnosed with heart block, complete heart block, as the etiology of his syncope. The cardiologist in Indiana diagnosed him with Lyme carditis and treated him with IV ceftriaxone, which he was still receiving via a PICC line about halfway through his planned course when we saw him. Interestingly, his bike trip was actually a cross-country bike ride that he had started up in New England and was riding across the country, actually interestingly enough through Lyme, Connecticut, and he had gotten sick in western Pennsylvania and ended up in an ER there, had a spinal tap performed and actually had aseptic meningitis. He convalesced for a few days and then continued riding. After his stay in Indiana, he actually required a temporary pacemaker, but he did really well. His EKG resolved, his heart block got all better, and he was on his way. The Lyme disease testing demonstrated that his serology, his screening serology was positive. The ELISA was positive. His IgM had 2 out of 3 bands positive, and his Western blot was negative. It was only 2 bands. I don't have it up here. It was only 2 bands positive. The patient himself was uneasy. He didn't like the fact that he was diagnosed with Lyme disease or a heart trouble from it. And he said he knew that Lyme disease is supposed to have a bullseye rash, and he never had one of those as far as he knew. And he wanted to know if he was going to be okay or at any further health risk. So if we look at some questions for this one, is the young man's diagnosis appropriate? Let's see if we can open this one to the audience here. Is the young man's diagnosis of Lyme disease appropriate? And again, we'll kind of go about 30 seconds on these polls. Okay, let's keep moving along. So I would argue that the answer is yes. And by the way, the split was about 80-20 on this one. The diagnosis seems epidemiologically and clinically likely. What I mean by epidemiologically is he rode through a very Lyme endemic area. And clinically likely, we know that heart block can be a manifestation of early disseminated Lyme. The laboratory studies also support this. His screening test was positive, his IgM was positive. Patients can present with evidence of disseminated Lyme disease even with no recognized tick bite and no EM rash. Again, I applauded the healthcare providers in Indiana for thinking about Lyme, and even though they are not from a Lyme endemic area. And I think this case emphasizes the importance of taking a travel history when you're evaluating patients with potential Lyme disease. By the way, the preceding viral meningitis, this aseptic meningitis that he had, was likely Lyme disease related. And again, I just want us to all keep that in our differential when we're seeing patients with an aseptic pattern on their CSF. Moving along, is his IV ceftriaxone appropriate? And I don't think I have an easy way on this one to turn into a question, so and this one's also a more opinion-based answer. I personally say yes. In this scenario, IV ceftriaxone would be valid. For only 28 days. There are several other options. He did have cardiac involvement, and again, the guidelines for treatment of cardiac disease say that after the heart block has resolved, you can switch over to PO therapy. to complete a 21 to 28-day course. However, the patient had meningitis as part of his spirochete dissemination. He had one of his earlier presentations, again, with this aseptic meningitis. So in this scenario, I chose to continue his therapy with IV ceftriaxone. It's more of a judgment call in that scenario, but I think a lot of us would continue along with the IV Rocephin just to complete his 28-day course to ensure maximum benefit. I told him basically he needed to expect that his cardiac and overall health should be great, and that just complete his treatment course and expect no long-term sequelae. He was certainly educated about tick-bite prevention strategies for his future. A very interesting case emphasizing the importance of travel history. Case 4 was a 45-year-old female from the eastern part of the state, Martinsburg, with a 1-year history of arthritis of her right knee that had been diagnosed as Lyme arthritis. She had no known tick bites and no known history of an erythema migrans rash, but certainly was an outdoorsy person and had a pet dog, so he was at risk of tick bites. She had been treated with several prolonged courses of PO-doxycycline and even did a recent month-long course of IV ceftriaxone, and she was frustrated that her symptoms in her right knee were not better. Her doctor had advised her to take additional antimicrobials, and she really came as a second opinion. Her physical examination demonstrated a large, swollen right knee. It was warm, relatively not as painful as I'd expect for how it appeared. Her synovial fluid sample had evidence of PMN predominance with 25,000 WBCs, and her workup for alternative etiologies such as autoimmune diseases and rheumatoid arthritis was negative. Her Lyme-specific testing demonstrated that her screening test, the EIA, was positive. Her Western blot IgM was positive, and her IgG was very positive at 8 out of 10 bands. So questions on this one. Is her diagnosis correct, given that she's not getting better? See if we can open up this one to the polls here. Okay, so some audience participation. Does she actually have Lyme arthritis? Again, we'll probably go about 30 seconds on this one to get the maximum percent involved. Close the poll in about 10 seconds. Okay, so about 75% of you said yes, she likely has Lyme arthritis, and I'm apt to agree with you on this one. Assuming that she had been evaluated for other rheumatologic and orthopedic conditions that could cause a similar swollen right knee, such as trauma or etc., I think it fits best. She's from an endemic area. Her symptoms are consistent with known clinical manifestations of Lyme disease, and the serology was very suggestive of infection with Borrelia burgdorferi. How would you explain her lack of response to antibiotics? I don't have an easy way to turn this one into a pollable question, but basically you'd have to remember that clinical improvement with Lyme disease, and not just arthritis, can take time. And I think this is an incredibly important part to emphasize and to counsel our patients, that it may take weeks to months to improve. Okay, the early manifestations tend to respond more quickly than the late, but even after appropriate antibiotic management or therapy, symptoms can persist for some time. Remember the entity of antimicrobial refractory Lyme? That's that term that actually would really aptly fit this case, where she has received appropriate therapeutics. She's received at least a couple courses of appropriate antimicrobial therapy and has had persistent symptoms afterwards. And basically at this point you're left with education, time, and only if it doesn't resolve after usually years or so would people seek additional modalities, potentially surgical, or even things like Plaquenil. Okay, now should repeated Lyme serologies or any other tests be ordered at this point? Let me see. I don't think I can turn that one into a pollable question either. So I'm gonna go ahead and answer that one. Think about that one for a second. Should repeat Lyme serologies or other tests be ordered? Let's see. I asked this question more or less to pound home a point that the serology that we currently have available for Lyme disease, unfortunately, does not reflect appropriateness of prior treatment. Now, any of you, those of you in the audience who have treated disease process like syphilis, know that after treating the spirochete appropriately, the RPR titer will gradually decrease over time. We don't have biomarkers for Lyme disease that behave similarly at this point. So the IgM and the IgG may remain elevated for years. It is true that the repertoire of bands tend to decrease over time, but at this point, due to the fact that different labs test different bands in different manners, there's no standardized mechanism of interpreting that, so you can't look at repeat testing. I think doing repeat testing in her would be ask more questions or open more questions than answers. So at this point, I would not. Some people would pursue synovial fluid sampling with PCR on the synovium, but it doesn't really change your management if you've already been appropriately treated with several courses of IV and PO therapy. The last case I have is a 54-year-old from Lewis County, West Virginia, that presented us again as a referral for Lyme disease. She had multiple complaints, including fatigue, joint pains, and poor memory that she described as a brain fog that was very disabling to her. It actually, she wasn't able to perform her job at a bank. She reported her symptoms had been present for 1 to 2 years. She had not traveled. Her examination really was non-revealing. Labs didn't have anything striking on them, except her Lyme serology was as follows. Very importantly, so her Lyme serology, her ELISA was negative. Her Western blot IgM had 2 bands positive, and her IgG had 1 band positive, again being interpreted as negative because you need 5 bands for IgG to be interpreted as positive. So her IgM is isolated IgM positivity with these symptoms of brain fog, joint pains, and fatigue. So let's see if we can open this one up to the audience. Is the serologic testing consistent with the diagnosis of Lyme disease in this clinical setting? And again, we'll use about 30 seconds here and see what we get. Okay, about 5 more seconds. We'll close the poll. Okay, so about 70% of you said no, that this is not consistent. About 30% thought it might be. I would argue that in this scenario, for the following reasons, this is not consistent. First of all, and I think most importantly, the Western blot really should have never been performed. According to the current 2-tier testing algorithm, the screening ELISA was negative, and any additional information we get at that point is really clinically uninterpretable. Okay, so furthermore, the symptoms had been present for more than 4 weeks. Once you've had symptoms for more than a month, you really expect the IgG Western blot response to be true and positive. Looking at that IgM Western blot in that scenario is likely to yield a false positive result. Her pretest probability is low, given that she was not from an endemic area and her nonspecific symptoms. I'm very comfortable saying that the serology is very likely false positive. The advice I would give her was that she does not have Lyme disease, and that alternative diagnoses should be entertained. By the way, thank you to the audience for participating in those cases. They're real kind of summaries on the case scenarios, so that really many factors play a role in diagnosing Lyme disease. You have to pay attention to what are the specific clinical manifestations. Make sure to take a travel history. Try to pay attention to what type of tick did bite the patient, see if it's engorged or not. Remember the importance of the 2-tiered laboratory testing, and remember the importance of how long patients have had symptoms when interpreting your laboratory criteria.
All right, we're rounding up the end of our webinar, but we wanted to leave you with some resources related to Lyme disease. Most important are your human resources. These are the 6 regional epidemiologists across West Virginia, starting with Jessica Woods in the Northwestern region, Deborah Ellison in the Western region, Michelle Trickett in the Southern region, Kimberly Klein, our Lyme disease guru in the Eastern region, Bob White in the Northeastern region, and Lindsay Mason in the Central region. In the Division of Infectious Disease Epidemiology, Dr. Dana Bixler is the director of our division, and she is also a medical epidemiologist and will be happy to take any questions you have about Lyme disease in West Virginia. I am Miguella Mark-Carew, the zoonotic disease epidemiologist in DIDE. Eric Dotsett is our state public health entomologist, and I put our email contacts because both of us are ready and willing to accept any calls or emails from you. Susan Stowers is our zoonotic disease data analyst and contributed a lot of the data for this presentation. And I also wanted to give a plug to our emergency on-call system where we take questions about anything. 800-423-1271, extension 1. We're available 24/7, 365.
Yeah, and certainly there's 4 of us here up at WVU. We'd be more than happy to take any referrals or answer any questions we could. You have a Mars Line slide on there? Is that coming up? We're gonna talk about the Mars Line, the medical access referral system, in a little bit. So that'll be an easy way to get in touch with us at any point, either to refer a patient or ask a question or two. Go.
We're going to break away from the PowerPoint quickly to go through some internet resources that we have for you.
Oh, here it is.
We can start off with the Mars Line.
The Mars Line is basically a mechanism where you call and talk to someone to take your question, and we'll page one of the infectious disease docs on call. And you can run a clinical scenario by us, run labs, or even arrange for a referral to us at any point. It's a nice, easy 1-800 number to get in touch with us at any time.
CDC has a really great website for information about transmission, treatment, symptoms, you name it, statistics on Lyme disease. But I wanted to draw your attention to their healthcare professionals section with links to information for veterinarians and also public health staff. And then back here for clinicians, continuing medical education credits are also offered by CDC. If you scroll down to the bottom here, there are 3 different options, 2 for healthcare, 2 for physicians, and 1 for nurses. Just wanted to take you to our new Division of Infectious Disease website. It was recently updated by our program analyst yesterday. So thank you to Bo Armstrong for doing this for us. On our main webpage, you can see we have Lyme disease as our hot topic, along with measles and Ebola we're going to phase out pretty soon. But on the left-hand side, you can click on zoonotic diseases, and if you are also interested in our mosquito-borne diseases and rabies data, you can click on one of these. But let's click on the tick-borne disease link. Bo also updated our Lyme disease, our tick-borne disease page yesterday, and it looks fabulous. Here is information about all of the different tick-borne diseases we have under surveillance. Veterinarians can click here for information about our veterinary tick submission project, or if you're interested, please visit. Shown here is our first tick surveillance intern in West Virginia. His name is Brian Hendricks, and he's a WVU student, PhD student. If you click on his link, it'll take you to where we found different ticks across West Virginia, and you can see this map I showed you earlier in our Ixodes scapularis distribution slide. There's other information about surveillance in general for tick-borne diseases, but if you want to click on Lyme disease, we also updated this page, namely for this webinar. But you can see we have different tabs depending on who you are for healthcare providers. We have links to the 2006 IDSA guidelines, the links to continuing medical education opportunities offered by CDC. Most importantly, I think, is Form A, which I really like for everyone to fill out and send back to me if possible. Even if you don't receive this from your health department, it'll really help us fill in some gaps when it comes to surveillance data. Go back. And then here, I'll talk about that later. I think we've covered all our internet resources. To summarize, we've got the CDC page on Lyme disease. We have our Division of Infectious Disease pages. We also have the Mars line. New this year, CDC has a bunch of literature about Lyme disease. We have those in our office, and we'd love to share them with you. They're taking up all of my shelf space, and I saved them up just for this webinar. We have the pocket minder that you can give your patients when they come in. It's the one on the upper left, shows them how to identify ticks and how to remove ticks. The tick-borne diseases of the United States is a manual about different tick-borne diseases and has information about treatment, how to identify ticks, you name it. If you'd like a wall sign, a trail sign for your office, we have a Prevent Lyme Disease trail sign. We have tons of bookmarks that you can give out to your patients, especially if you're in Lyme endemic areas. We also have what you need to know. That's the one on the second line with various information about Lyme disease. And then this, we're just going to close with the big picture. We know that everyone plays a really important role in surveillance. Healthcare providers, you are crucial. Public health, you are also very essential. But we all want to work together to improve Lyme disease surveillance in West Virginia. Our numbers are relatively low compared to other states, but I'm pretty sure that we're missing a lot of cases. So by us working together, we can see the big picture and get a better idea of what's going on here in West Virginia.
I really appreciate your attention and participation.
Yeah, we can open up for questions now. If anyone has any questions, please click on the questions section. We do have a question. Oh, we have lots of questions.
Okay.
Wow, audio is poor. Sorry. Let's see.
We're just seeing if any of them need
Stop sharing the screen for 1 second while we figure this out. For reception.
we may have to have them email us the questions. Should we do that?
Yeah, maybe we'll just do that.
From an IT standpoint, we're having a hard time finding your questions. We have our email addresses up there. I would actually love to try to answer some of the questions that you all have addressed. We have both of our email addresses up there, and we'll eagerly anticipate that, hearing from you, and try to respond individually to as many questions as we can.
And look forward to an email if you did want to see continuing medical education credit from, I believe her name is Katie, after this webinar.
Thank you very much.
Thanks so much.